Now, let's go one by one. Professional judgment at all times, factoring the context. This is more and most important. Now, please remember that teleconsultations is totally different from face-to-face consultation in several ways. When a doctor comes to my consulting room inside Apollo hospitals or whatever hospital you are working in, the patient may never have met you before. Patient has not seen you before the first time. He assumes, he takes it for granted that the CEO or the medical superintendent or whoever is in charge of the hospital has identified your credentials, that you really are a registered medical practitioner, that you really have passed an examination, that you are a dermatologist or a neurosurgeon or a cardiologist, etc., etc. It is implied because you have a consulting room either inside a hospital or even if it is a standalone clinic, you have put a board, you have put your name outside, etc. Whereas in a teleconsultation, a patient only sees me or you for the first time. So he has no idea. Now I will be giving this teleconsultation most probably from my house. The whole idea of teleconsultation is to work from home, and therefore the patient needs to be satisfied. He needs to be 100% sure that you are whom you claim to be. Similarly, in teleconsultations, since most of the time you are giving a second opinion, you are a specialist or a super specialist, I assume, unlike a face-to-face consultation, you have already been provided most data. You may not even physically examine him. You are not going to take the blood pressure, the pulse rate, etc. But you will get a report from an MBBS doctor or even from a nurse or a healthcare provider that this is his BP, this is his blood sugar, and this is he's got RALs and Ronchi on auscultation and so on and so on. What should I do? Now, this is the name of Mr. ABCD, age 45. The CT scan which has been sent to you in a store and forward the previous day or a few hours earlier has a particular name and age and sex. You also need to be sure that you are really consulting, teleconsulting with only the patient who appears on the screen. Therefore, the Government of India practice guidelines, and I think it's a very good suggestion, clearly says that the doctor is responsible for ascertaining who the patient at the other end is. Therefore, unless you know for certain, for example, a review patient, you have already seen this patient earlier, it makes sense on the first time to get an Aadhaar card or a driving license or a passport or whatever you want, some photo ID card which confirms to you that the name and the photograph belongs to one and the same person. Similarly, I'll show you an illustration in about 10-15 minutes. Similarly, when you appear on the screen, it is necessary that your photo, your registration number with the council with which you have registered also appears on the screen, and a certificate from the Tamil Nadu Medical Council or whatever it is. I mean, this is according to the rules, and I see no reason why we shouldn't follow this. In a follow-up consultation, this may not be required for both parties. So identification of the patient and identification of the RMP is very, very critical. The first step under the telemedicine practice guidelines. I had already informed you yesterday that privacy and security are very, very important. You are not going to do a rectal examination, a vaginal examination, an examination of the abdomen, whatever it is, examination of the skin in the uncovered chest or uncovered abdomen, etc., with number of people inside the room. It will be in your examination couch. You will, of course, have, if you're examining a lady patient, you must have a chaperone when you're examining a lady patient. Similarly, the same rules and guidelines follow for a remote consultation also. When you're examining a woman patient, you're doing a teleconsultation, you're a dermatologist or you're a general surgeon, there is a lump, a lump in the chest. You want to clearly see the lump. Varicose veins, varicose veins in the upper part of the thigh. From the calf muscles, it extends wherever it is, etc. A capillary nevus. There are so many dozens of conditions where you need to physically see whatever is a problem. Please ensure that a woman is present in the remote end when you are doing a teleconsultation. It is wrong, ethically wrong, legally wrong to do a teleconsultation for a child, anybody below the age of 18, unless the parents are there. Or, of course, it's a 16-year-old boy, 17-year-old person. The parents have initially permitted you. That is your individual judgment. Of course, the context may be different. So long as you are aware of this and take the necessary precautions, it is fine. Now, having finished that, the next step, mode of communication. Now, teleconsultation, the only word common is tele. Tele may include audio, video. It can be communication through text, through a chat box, through a chat bot, where a machine does the communication, or a combination of all the above. Again, clinical judgment, professional judgment. You and you alone decide whether a telephone call will be enough. After all, it is far easier to do a telephonic consultation than to do a video conferencing all the time. For example, this morning, I got a telephone call of a patient whom I had given a teleconsultation just 3 days ago. He wanted a clarification on the anticonvulsants which I had prescribed. Now, for this, it is a teleconsultation. So I obviously decide, I've seen him only 2 days ago, an elderly person, carbamazepine. He did not have the particular drug which I had prescribed. He wanted to know if another company had those 200 mg can be taken, broken into 2, and so on and so forth. So I said a telephone consultation will suffice. So it is entirely your decision on what you do. The type of video consultation you do, again, just half an hour ago, I gave a video consultation on WhatsApp. Though I would not like to do this at all. This was a person from Kashmir, from a house of a person. The patient does not have access to a laptop, does not have a video camera, etc. I had already seen the MRI. I had already seen all the investigations, but I had insisted on directly talking to the patient, examining the patient. I refused to give an opinion on an MRI, and because of this, and this patient was already presented to me by a relative. The patient only speaks Kashmiri, but I said I must see the patient, and therefore I consented to do this on a WhatsApp video with all the details recorded elsewhere. So it is your individual decision. Now, the consent from a patient again differs on if it is a direct or an indirect. What do I mean by direct and indirect? This rule, this is probably because of the pandemic. It is extremely broad-minded rule. The rules permit a surrogate decision maker. In other words, let's say you have a patient with dementia, cognitive changes. The person is mentally not oriented enough to ask for a neurological consultation. He has an impairment of memory every now and then. He is just not able to process information. Therefore, his wife or his son or daughter or brother or sister, whatever it is, wants a neurological consultation. In such a case, someone else has a right to fix a teleconsultation on behalf of the patient, even without the patient's consent. Now here, when we say without the patient's consent, what we mean is the patient's faculties are not enough for him to understand that a consent is necessary. And in such cases, you need to satisfy yourself that the person who is asking for a consultation is a genuine person. Now, 99% of the time, there will be no problem. But as medical doctors, we should be prepared for the 1%. Just to give you an illustrative example, I remember long ago, maybe about 13 or 14 years ago, I don't remember, I was actively involved in multiple organ transplantation, brain dead patients. I used to take proactive measures, inform the transplant surgeon, etc. And I got the consent from the wife. Everything was done. And then to my utter shock, when the organs were about to be retrieved, a woman comes and she says, how can you give consent? I did not give consent. I am his wife. And then we found that he had two wives, and the second wife did not permit the organs to be retrieved. Now, these are all extremely rare situations, but it is totally different when you're dealing with it physically and we are dealing with it remotely. Therefore, unless you are the slightest doubt you have, the slightest doubt you have that the person asking you for the consultation may not really be the immediate family member, may not have the authority. It could be an employer, and you have to be very careful. If it is an employer, you have to be absolutely satisfied. So this is again your prerogative. So please ensure this. Now, normally what do we do in a consultation? Just divide whatever you normally do into various components. What do? I listen to the history. I am the old-fashioned doctor who still believes in listening to the history, because I think history can give you the diagnosis quite often. After that, I physically examine the patient virtually, remotely, come to a tentative differential diagnosis. I refuse to see any investigations since I have already made a tentative differential diagnosis. If the patient has already been investigated, partly investigated, I review all the investigations only after step 1, step 2 is over. After that, I discuss with the patient in the presence of the immediate family members, or in certain situations, I may decide to do it later. But whatever it is, always, I'm sure all of you do the same thing. It is necessary that we discuss counseling, further management, natural history of the untreated condition, different treatment options. Do we operate? Do we radiate? Medical management, which comes first, etc., etc., etc. All this takes 10 to 15 minutes, what we call counseling. So all the telemedicine practice guidelines have divided the entire process of consultation into diagnostics, into counseling, into healthcare management, promoting health literacy, and so on. So you need to be aware that you do all this. Now, patient records. This is a question which I'm often asked. Now, of course, the telemedicine guidelines are reasonably clear about it, though there are one or two lacunae doubts also even now. Now, medical records have to be maintained. The only good thing about it is the government has said you decide on how you want to store a teleconsultation. The exact words they have used is technologically convenient manner. Now, we have had several rounds of discussions among ourselves, and we are of the opinion, and this is what I say, as a past president of Telemedicine Society of India, I am saying that you need not maintain every single transaction which took place, but whatever you normally do in your day-to-day practice. For example, a patient comes to me with convulsions. What do? I write in the case sheet, history of seizures, eyewitness so-and-so, etc. I say no neurological deficit. 3 words I use. I do not write motor system normal, sensory system normal, no perianal anesthesia, plantar flexor, knee jerk, brisk exaggerated, etc., etc. My clinical judgment, if I think the fundus should be reported, I will write. So here what do? I write only what is negative. Now, in a particular case where I think from the history there is headache, there is vomiting, possibility of a space occupying lesion, I should examine the fundus. I'm not able to examine the fundus remotely. I write in my case sheet, fundus not examined, etc., etc. After that, most important thing is you have to record your tentative working clinical diagnosis. A year and a half ago, the Bombay High Court issued an arrest warrant for an obstetrician gynecologist, and then unfortunately the IMA at that time used this, was wrongly misinterpreted, and everybody said telemedicine practice is absolutely illegal. What the honorable judge said was that the doctor erred in not coming to a diagnosis, in not coming to a conclusion, and prescribing a medicine based on a telephonic conversation without coming to a diagnosis. The law does not prevent you from prescribing even after you listen to somebody on a telephone. However, the prescription which you write must contain your working tentative diagnosis. For example, I may even write NYD headache. That's fine. Not yet diagnosed headache, which means I am not sure that this is definitely a case of migraine. I am not sure whether this is definitely a case of meningitis, etc., etc. So you need to write the tentative working diagnosis. That is important. Now, practically speaking, at least for the next couple of months, next year, until these guidelines become clear, what would I do? What did I do this morning? I wrote down the physical findings in an X-ray, in my prescription pad, and then very simple. I'm doing this consultation from home. I have a scanner, everything. So I scanned it on my scanning machine, put it into my laptop. Alternatively, I will take my phone, take a photograph of of my prescription pad, and have it transferred. Now, I do not do many consultations because I actually, not in active practice. So I do a few consultations. But for doctors who are doing regular consultations and, maybe you're going to do 5 a day, 10 a day, 15 a day, etc., I would strongly suggest you have a separate email ID, a separate WhatsApp number, maybe even a separate mobile number, maybe even a separate laptop or a tablet, etc. This will ensure that every single patient transaction is recorded. Otherwise, it will be very difficult. You'll have to spend a lot of time if you're going to take all this data from one machine and retrieving it again will be extremely difficult unless you have an electronic medical record. Yesterday, I had also mentioned the importance of having an electronic medical record.